Good evening, everyone. We welcome you to Doc Talks with Dr. Forrest Tennant and friends. We are entering season 6, episode 21, and we have a powerful show ahead of us. Dr. Tennant, you have so much to offer. We're looking forward to hearing what you have to share with us tonight. Go ahead and take it away, sir. It's all yours. Thank you.
Thank you very much, Jamie. Yeah, we'll have a great program tonight. I've asked Dr. Ibsen and Dr. Guest to come up with some special things they're interested in. But what I want to talk about tonight is something that we have not addressed on this show, but unfortunately has to be addressed. I'm going to start off by saying that we formed Arachnoiditis Hope 8 years ago, and the goal was to bring diagnosis and treatment to every community. And right out front, one of the very first things that we did was to offer to patients and to physicians the ability that we would review their MRIs and their laboratory work and help them develop a treatment plan to get started. Now, we've continued that over this last 8 years. My main research assistant tells me that she thinks we've reviewed 3,000 cases from over 60 countries. And maybe we have. It's been a whole lot. But what I want to get at is this. I felt that by this time, we'd almost be out of work. Adhesive arachnoiditis is supposed to be a rare disease. It's supposed to be on the way out of here, but it's turning out to be just the opposite. We're starting to have people all over the country, all over the world saying, this disease seems to be increasing, not decreasing. And it seems to be. Our demand to review cases keeps going up, up, and up. And I want to talk about some sad but factual things going on tonight. And I realize I'm talking to the choir because the choir is going to have to sing out there a little bit because you're going to have to do some educating on what I'm going to talk about tonight. Now, what we're going to talk about tonight is what seems to be causing this increase in adhesive arachnoiditis. And it all boils down to medical spinal punctures, okay? And every week I'm reviewing a case. It's either a spinal tap, it's either an epidural for delivery, or maybe just a regular epidural. And these people are developing adhesive arachnoiditis after these procedures. Now, we're going to start off tonight with some basic facts. Now, the basic fact is this. Any spinal puncture, whether it's for a spinal tap, anesthesia for delivery, or whether it's for therapeutics to treat pain, carries a risk of adhesive arachnoiditis. The risk is not zero. It may be very low, but every spinal puncture carries a risk for developing adhesive arachnoiditis, which gets into one other thing. I thought by this time every consent form in every hospital and pain clinic would at least mention this, but one of our real problems is people are not being informed about this risk. It is there and will continue to be there, okay? Now, as I've been reviewing cases, it's become very clear that 90% of cases of adhesive arachnoiditis are from after a spinal puncture, either a spinal tap, epidural for delivery, or epidurals for therapeutics. Only about 10% are cases that do not involve spinal punctures. And those are cases that have usually a terrible spinal accident, like a terrible fall or electrocution, or maybe Lyme disease, one of the infections. But basically, what we're talking about here is that adhesive arachnoiditis is a complication of a medical procedure called a spinal puncture. And that spinal puncture has 3 types: spinal taps, epidurals for delivery, and epidurals for therapeutic uses. Now, this week, because I've been quite concerned about this increase or seemingly increase in number, I had one of my research associates do an AI search under Google to find out how many cases, how many epidurals are being done each year. And the number is shocking. Now, grab your seats, folks. Grab your seats. Whether you believe AI all the time or not, or whether you believe Google all the time or not, AI Google says that between 9 and 11 million epidurals are being done each year in this country for therapeutics, between 9 and 11 million. It also says that between 1.6 and 2.4 million epidurals are being done for birthing delivery. Now, that's 12 or 13 million people. Now, depending on what source you read, I've got one source that says over 2% of epidurals will end up with adhesive arachnoiditis. You just do the calculations. If you've got millions of people getting these spinal injections, how many new cases are we going to get? Well, my mailbox is saying a whole bunch. Okay. Now, the mess gets messier. Now, here is what I'm getting at. What I'm seeing out here is tragic. And what I'm seeing is this. Almost I hardly get a case now in which they were told on their informed consent that they might get adhesive arachnoiditis after a spinal puncture. So the hospitals and the doctors have just ignored this and not telling anybody about the risk. All of you hearing this tonight need to get that word out there. People need to know if you're going to have an epidural or a spinal tap, you need to be told you do have this risk of this rare, terrible disease. So that's number one. Now things get worse. Now the tragic to me is that people, when they have these procedures, and a lot of you seeing this tonight can relate to that, at least half, if not three-quarters, get the pain right on the table, okay? Right at the time of the epidural for birth or a spinal tap or for therapeutics, they feel pain. All of a sudden they're laying there and all of a sudden they've got maybe the worst pain they've ever had in their life. And that pain may be so bad it can hit their head, hit their back, cause their legs to start jumping. They get off the procedure and the doctor will tell them, oh, don't worry about it. It's just going to go away. This is all natural. Well, it's not all natural. And so people are being sent home in terrible pain, no anesthesia, no opioid for relief, no idea what's happened. No idea what's happened. And to make matters worse, 72 hours later, a week later, these patients are going back to their doctor, and their doctor's telling them, don't worry, this is just all natural, it's going to go away. And at the best, they might give them a little Topamax or some gabapentin, or tell them it's all in their head and go away. In other words, the tragedy of all this, we have hospitals and doctors doing these procedures, not giving them informed consent, and then when they get the problem, they're ignoring it. They say it's someone else's problem, it's not ours. In other words, fundamentally go away. But what I want to talk about tonight is what happens. We do know something that's not well appreciated, and everybody needs to be aware of this. Now, I'm going to do one of my famous, difficult to understand diagrams. Okay? Now I'm going to draw something here for you. We're going to draw a spinal canal cover. Now, I'm going to put this up here. I hope you can kind of see this. This is actually the canal cover that I'm trying to show here. Now, in the lower spinal canal, in the lumbar sacral area, the spinal canal cover is comprised of two layers. The outer dura, which is nice and tough, it's got nerves and a blood supply, and the inner layer is the arachnoid. Now, there's a couple of things about the arachnoid that people don't understand. It was called arachnoid because it looked like a spider web, and it's just about that fragile. It's very thin, very white, comprised of very thin threads, and that was why it was called arachnoid, like a spider web to start with. But that arachnoid does not have its own blood supply. That's very important because it can't fight off infections or inflammation like normal tissue, okay? So the arachnoid is a very special tissue that lines the inner canal cover, all right? Now, of course, inside the spinal canal, you've got fluid, okay? Fluid. Now, there's something about spinal fluid that's not appreciated. Spinal fluid is, first off, life-sustaining. You can't live without spinal fluid. And in fact, the good Lord has the body turn over and give you brand new spinal fluid every 4 to 6 hours. It's the most fragile, volatile fluid in the human body. I mean, no other fluid like blood or eye fluid or saliva turns over every 4 to 6 hours. But we get new spinal fluid every 4 to 6 hours. Why? First off, it carries all the nutrients of the body into the brain and the spinal cord to keep it alive and functioning. It also lubricates the whole system, and it's also a protective substance. It keeps things out, and it's actually also a conduit for when you have metabolism there inside the spinal canal. It washes out all of the biologic waste. And so spinal fluid is very, very precious, but there's a problem to it. Spinal fluid is just fine. The cells, like the arachnoid cells, the cauda cells, the spinal cord cells, are used to this fluid. It likes the fluid. But inside those tissues, spinal fluid is toxic. Okay? So if spinal fluid gets into a crack or a hole inside the arachnoid, it is toxic. It's like putting acid on the skin. And so what happens during this spinal puncture, if we get this needle, for example, going through the cover, you've just put a hole in the cover. And in some cases, that hole is going to be big enough. And just remember all those cases when they had to poke you 6 times to get in. You just made a real mess of things and allowed that spinal fluid to get inside the arachnoid membrane and maybe inside the dura. When it does that, bang, that's when you get that terrible pain right there on the table. That's what it's all about. Spinal fluid has gotten inside the tissues where it doesn't belong. It's just like putting hydrochloric acid on your skin. Okay? That's the pain you're going to get right then and there. Now, so that's something that's not well appreciated. One other thing that's not well appreciated is this. When you take an epidural injection, you theoretically are putting the fluid outside the dura, but that epidural space isn't a real space. It's just a little groove between a couple of tissues. And if you put fluid in there too fast, you may rupture or cause a fissure or a break in the arachnoid. And particularly if you're trying to deliver a baby where you're pushing and pulling all the time, that kind of pressure is not helping. You may rupture a little tear. All you need is a little old tear in the arachnoid to let in the spinal fluid, and bang, you've just got it. You have just allowed toxic spinal fluid to get inside where it doesn't belong. Now, if it does that, it's like any kind of irritant on the skin. It's going to cause inflammation, and that's what happens. And so the origination of all of this is a hole in the arachnoid or a tear or a fissure or a scrape of some kind that happens during the medical procedure, during the puncture, that allows the spinal fluid to come in contact with the interior of the arachnoid membrane. As long as it's on the surface, no problem. That's the way it's supposed to be. Just don't let that fluid inside those tissues, because then it's an irritant and it's going to start inflammation. And once that inflammation starts, you're off to the races. If there is not the right intervention, you may end up with adhesive arachnoiditis. Okay? So now let's go on for just a minute. I have yet to have any physician out there doing these things, or any woman or man who told me they got this terrible pain on the table were ever given any medication for it. The truth be known, it's my recommendation. You get that pain right on the table where you're being given that for delivery or a therapeutics. You need to be started on a 6-day Midroll dose pack right then and there. You need to be given a shot of Dilaudid if your pain is too bad you can't stand it. In other words, treatment should begin the minute that you get pain after that spinal puncture. Okay? It should begin. Now, another thing that should happen, let's say you've delivered your baby, you had this terrible pain during delivery, and here it is, 72 hours later, you're in terrible pain, you got a headache, you can't sit up. If you do, you fall over, you're dizzy, you've got a terrible back pain, you've got a burning feet and stabbing pains in your leg, and you know you're miserable. What should happen in 72 hours? Well, you really should be started on IV methylprednisolone, 50 or 100 milligrams a day for 5 days in a row. That would be ideal. If you can't get IV, at least you should have another Medrol dose pack along with ketorolac for about 3 days. And I also like progesterone. Progesterone turned out to be a great healer of spinal canal tissue. So I like to use progesterone in emergency situations. The bottom line is we're not seeing any of this. In other words, what we've got out here, we've got all these hospitals, all these surgery centers, all these doctors giving these risky procedures. They're not telling us there's a risk. And then when they get the problem, they're not doing anything. They're just letting the patient go on their own, sort of in a cavalier way of saying, you're on your own. It's not my responsibility. No, I did the procedure. You've got the complication. You're on your own. Now, guess what? With that kind of an attitude, we have another profession out there who is listening, and that's called lawyers. Okay? That's called lawyers. I'm here to tell you that the lawsuits have begun, and it's inevitable given this terrible situation out here. The first lawsuit starts on the 23rd of this month. It's a multi-million-dollar suit in which a woman has exactly what I just described. Okay, epidural for childbirth, pain on the table, nothing given, sent home, no follow-up, and now here she is months later, crippled with adhesive arachnoiditis. Now, to make matters worse, there's something else going on out here which is just awful. The radiologists aren't helping us. The radiologists are reading the MRIs and they're saying, oh, we don't see anything. Well, you don't develop the signs of adhesive arachnoiditis after a spinal puncture for at least 6 weeks or 12 weeks. It's going to be a delay, but what you can see is inflammation signs in the caudoequina and the arachnoid, but radiologists are not reading those signs as of yet. But you can sure see them there. You get a thickening of the arachnoid membrane, and I can tell that inflammation has already started. To do that. To make matters worse, we have another thing we have a group of doctors out here and neurologists who think if you get a headache or a back pain after a spinal puncture, it's a leak. Most of the leaks being treated today aren't leaks at all. They're telling them that because they don't know what else to do, and they're actually giving people blood patches that don't have leaks, and that's even makes things worse. And so we have a mess out here, folks. We've got, like I say, millions of people getting these procedures every year now. We've got more and more people developing this, and the lawsuits have started. I know of 2 other lawsuits out there, but we do have the first one coming up in about 2 weeks, and it's a biggie. It's in the state of Oregon, and it's going to have quite an impact on this system, win, lose, or draw. It does go before a jury, and so this jury is getting well educated. But I wanted the arachnoiditis community to be aware that we have this problem out here. And I hate to badmouth a lot of people, but a lot of people need it right now. They've got to straighten out this system. So let me just close this by saying we need informed consent for anybody who gets a spinal puncture, that the risk is low, but there is a risk of adhesive arachnoiditis with every single spinal puncture that is done. That's number one. Number two, when that person is on the table and develops that severe pain, that means that arachnoiditis, the arachnoid membrane has been broken. It has a hole, has a fissure, it has a crack, and spinal fluid is infiltrating that tissue where it's not supposed to be. And you're setting up a system to where inflammation is going to start growing and lead to adhesive arachnoiditis. And my last thing is this. If a doctor or a hospital thinks they're good enough to do a spinal puncture, they better darn well be good enough to do the treatment if there's a complication. And therein, I think, is where a lot of the liability is going to come in. This idea that they're not being treated right afterward is just not correct. So I'm asking anybody who's watching this should become an educator. Everybody needs to know that this is a big problem. Millions of these procedures are being done. Adhesive arachnoiditis is going up in incidence, and a lot of this can be prevented. Now, lastly, how successful is the treatment after the spinal puncture? About 50-50, unfortunately. It is not always successful, but you have to try it. We have to try to prevent these cases. So anyway, I hate to have this to be a program of dirty laundry, but that's what it boils down to, folks. So you're going to hear more about it because it is an issue that just simply has to be corrected. With that, I'm going to see if Dr. Ibsen's around here because he's got some information on a whole different subject. So, Mark, are you here?
I am. Thank you, Dr. Tennant.
You bet.
I'd like to stick with this. The dilemma this information gives to an ER doctor like myself is that one of the major paranoias for an ER doctor is misdiagnosis. Missed appendicitis, missed pneumonia, and in children, missed meningitis. If a child gets meningitis and the diagnosis is missed, it's a lifetime of disability and huge settlements. So in my ER career, we did lumbar punctures willy-nilly on any suspect infant, anyone less than 6 months old, with possible sepsis, or any sick kid with a headache and a fever and a stiff neck. They've got to have a lumbar puncture right away. And I must say that the ER docs may not be the number one skill set for performing a diagnostic lumbar puncture, but if it's 3 a.m., this is going to add some wrinkles to the care of the sick pediatric patient. Have you received any feedback about this, or heard anything from the American Academy of Pediatrics or the American College of Emergency Physicians about it?
Not a word.
Yeah. Wow. Thank you. So ultimately, it seems to me that we're going to have to discuss this as clinicians. I no longer practice emergency medicine, but it seems to me that at some point we will have to treat meningitis without the full diagnostic workup if we're considering that we're harming patients, because a 2-month-old infant with a septic workup or a 2-year-old with a viral meningitis who doesn't need antibiotics, they're still going to have those procedures done, and they're going to need to be done by radiologists, I think.
Very good.
Thanks.
Mark, you were telling me earlier you've got some other news on 2 or 3 fronts. So
I
I want
do.
the Ibsen report.
Okay, so I have several patients who are on injectable hydromorphone, and there's been supply chain issues with a shortage of hydromorphone in the country. Last year, or in the fall of 2023, there were 2 hurricanes that hit the manufacturer in Tampa, and those supplies were interrupted. This year, there was a 17-day interruption in supply, followed by some patients having reactions to the medications. And the one I discussed with you already, the initials are DE, Dr. Tennant. This patient received her first hydromorphone after the interruption in care, and she reacted to it like it was Narcan or something. She had a terrible reaction. And this is the only medication that works for this patient. So I think it's instructive for us to talk about real quickly, not to scare anybody, but essentially, this patient had several shipments of the medication, and she could not tolerate the injection. So she was wondering what to do. I was wondering what to do because declaring her allergic to the medicine, the only medicine that saves her life, is not an option. So we did some problem solving. And I think that the takeaway is this: is that if you run into a problem, and you're on your last medication that you can use, you have to work the problem and figure it out. And I have a happy ending to this story. The patient, I suspect, may have had almost like, I'm just guessing the mechanism, and please help me with this, Dr. Tennant. The patient was reacting as if they were allergic to the medicine, and then it looked like it was maybe a mast cell situation, and she was taking antihistamines, and that didn't seem to help. And ultimately, we did an experiment, and we ordered the medication without the preservative, and she could tolerate that just fine. And then her problem was, well, that's very expensive to get that medication, like $3,000 for a week worth of medicine. So the experiment worked. We found out some information. And then she began to, we put her on some steroids and we put her on some histamine blockers, and she was finally able to re-expose her system to this medication, and she's now able to tolerate the standard hydromorphone with preservative. I don't know if anybody else has had this problem. It was vexing at first. Dr. Tennant, you provided us some guidance with this as we played with it, and the happy news is the patient can now tolerate the hydromorphone with preservative. And I guess the takeaway is if you're in desperate straits, you got to figure out a way to find a medication that works, or find a way to keep that medication working if it's the only option you've got. Any response, Dr. Tennant?
Just one. Over the years, there's been observed that opioids and histamine have a relationship, and nobody quite understands it. Years ago, there was an antihistamine on the market called pyrobenzamine, and all heroin addicts like to take it with their heroin because it would potentiate the heroin. And occasionally, we've had this situation like you see with this woman. It looks like they're almost allergic to the opioids somehow, but they're really not. The opioids somehow, in some people, even once in a while, will activate the histamine. But I'm glad it worked out for her because she's got to have it. And you've done a great job of working through that, Mark. Congratulations.
Yeah, thank you. And if anybody else has, maybe we could do at some point, Dr. Tennant, maybe you and I can work on getting a case report done, so that other people can be informed by this situation.
Yeah.
Next is I gave you guys all some news last week about a patient who was arrested, and I did a video about it, so there's more detail on my Facebook Live. Essentially, the patient is a patient of mine who lost access to their pain medication in California, and cannot take the injectable hydromorphone, is clearly allergic to it. Oh, well, maybe we should look into it. At any rate, and I didn't think about that till just now, so put a pin in that for me, everybody. So he came to Montana to pick up his medicines. He comes every 2 weeks because his doses are high and he's an ultra rapid metabolizer. He gets on his plane and flies back to California, and he gets in his car and they pull him over for possible driving under the influence. And the police in the town in which he's in pull him over, not highway patrol or anything. And then they incarcerated him and took his medication away, including his insulin. And he spent 30 miserable hours in jail, and then was bailed out. The I don't have an ugly end to this or a happy ending yet. The patient has been without his medications for 15 days now, and is miserable and in bed and in withdrawal, and stretching out whatever medicine he has left from previous stockpiling, and having trouble taking care of himself. He has a wife who works. He's got kids in college, and the key point is he has been unable to find an attorney yet, and it's been 15 days since he was arrested. So my tip for everybody is looking for an attorney after you've been arrested and charged with drug dealing, essentially. I think that's what they're going to come up with charges. Possession of narcotics with intent to distribute. Even though there was no time for him, unless he was selling hydromorphone to people on the plane, there was no real time for him to actually divert this medicine. The other tragedy about this is this is a patient who's on my subpoena list. So they've subpoenaed me about this patient. They have his records. They obviously haven't read them to tell what doses he's on, and he's on very high doses. And then they use this information to target him and set him up and arrest him. So don't get targeted. How do you not get targeted? Have an attorney that you can call 24/7. And just any attorney can do the initial work that you need to get out of this pickle. The other thing is the recommendation that we're coming up with is don't drive to your pharmacy. Let somebody else drive to help you pick up your medications, so that they can't accuse you of driving while under the influence and seize your medications. I know it sounds terribly cruel. As far as I'm concerned, it is terribly cruel. It's as cruel as abducting a 5-year-old patient and sending them to Texas. But at any rate, these medicines have been confiscated. And we're looking for there's a GoFundMe for this. Maybe I'll get Jamie to add this to the thing afterwards. And the patient's right now looking for an attorney, and the best he can find is somebody for $40,000 in addition to the $40,000 bail that he posted, which was 10% of that. So he had to take $4,000 to get his bail. So we are vulnerable and we're being targeted. And I'm upset about it, but on the other hand, they have way overreached in this particular case, and this should be something that the patient can extract himself from. And I'm ready for any questions anybody might have.
Yes, I have a question. Mark,
Yes, Norm.
Dr. Ibsen. First of all, let me ask you a question. You said drive to your front. In this case, this patient wasn't driving from the pharmacy; they were driving from the airport. So
Yes.
that makes I understand what you're saying, but it does make a huge difference. It sounds like it was targeting. The other thing that's interesting, and this is kind of like an offbeat of the whole thing, is that, if this guy was going from pharmacy to pharmacy, okay, that'd be pharmacy shopping, or he's going from doctor to doctor, that'd be doctor shopping. Now, he's going from, and this is how they play these words, he's going from lawyer to lawyer to look for somebody to defend him.
Yeah.
It's just like that macaroni and people share their potato salad kind of connotation. He's going from lawyer to lawyer. Why is that not lawyer shopping? I mean, where's the statute on this thing? And again,
Well, I don't
we
think there's
see
any particular
right.
statute about looking for a different attorney, because the attorney doesn't have prescriptive capabilities for controlled substances. So in this particular case, the patient takes a large dose. The agents involved look at this large dose and they're saying, how could you possibly tolerate this large dose? But these agents are not trained in medicine, and
Right.
they're
But
not clued in.
the law is very specific here that, the DEA does not and is not permitted to determine dosage or the amount. That is a decision-making process of the physician, which would be you. Then how then is that then drug trafficking, when in fact he just got off the plane, got got into his car and drove off. And then you mentioned before that they did some sort of examination on him. And we talked about that a little bit on the
Yeah,
phone.
he had a
Was that a medical examination?
well, no, it's a definitely a forensic examination or a legal examination. But any driver
But
who,
a medical issue, a medical thing was determined because
yeah,
they
well, it was
seized his
determined that
medicine.
he, they gave him a breathalyzer, and he didn't have any alcohol in his system, and they
Mhm.
claimed that he was weaving in his lanes, and I haven't seen any video to either confirm or deny that. And so, as far as I know, it's not illegal to change lanes um, while you're driving. But at any rate, they tested him at the site. However, the patient is ill. He's got a neuropathy. He's got poor balance. He's had a brain injury, so he can't really pass a field sobriety test. Nor could somebody in a wheelchair pass a field sobriety test. So it doesn't mean they're not capable of driving. It just means that the test is not very specific for finding out what somebody might be intoxicated from. And of course, he has diabetes, and his blood sugar was eventually checked at the jail, and it was elevated.
And they seized that insulin medication. Is that
They
correct?
took
That
his
also
insulin as
correct?
well as his pain medications. That's
All
correct.
right, all right.
Yeah.
So this sounds like a serious case of targeting rather than anything, because I don't think the insulin would cause you to bob and weave or anything like that,
No, no,
from
and
the
and and,
store.
and,
Yeah.
and the patient has previously done testing where he's taken his whole medication and then neurologically is fine. So he's been tested
Okay.
in that way before. But it seems like an overreach to me. But it's a the reason I want to make this point clear to everybody is that people are careful to not get pulled over. Um, and if they are pulled over and you're taking any particular medication, apparently now the DEA and the local constables feel like they can confiscate your medicines and charge you with felonies.
That they have access, and I do know that I've had people say they were pulled over and that the state police at the time had access to the e-force is what they call it down here, the PDMP system, and that sort of thing. Okay,
Yeah,
I'm,
I bet Scott knows about this, but there are states, Montana's one of them. So evidently California's not, where you have to have a warrant to actually query the prescription drug medication program. So, but that's only like maybe 9 or 10 states where that warrant is required. Scott,
I've lost. Oh, hold on. Oh, goodness.
I can hear
Go
you.
ahead, Doc.
Oh, okay. I've lost everything. Yes, I don't know about other states, but I do know that California, you do have to have a warrant for law enforcement other than, to look at PDMP data. The only
but
people that don't is the Board of Medicine and the Board of Pharmacy.
but that raises a serious issue then. Why was he being tailed by two agents from that Montana that met him at the and identified themselves as being from Montana that met him at the local police station? Who precipitated this? And um, it and then uh, charge him, a person who has a medical condition, with or alleged, say that that's drug trafficking. At least that's what they're trying to allege. I haven't seen where they've indicted or gone to the grand jury yet,
He
but
has
it
an
raises some
appearance on
very
the
serious
26th of this
issues.
month. Yeah.
Okay, is he going before the grand jury like you are?
No, he just has to appear and be arraigned and see if what the charges end up being, and either plea or be represented, and he hasn't got representation yet. So clearly, the only dots I could connect is that he's on the list of patients that I was subpoenaed about back in
He
last April. So
So they're
they
going to
got my
charge him
medical
with,
records on him.
okay, so there's another, they're going to charge him with being ill. He's taking the medications because he's sick, because he's got a disease state. And if I remember correctly, that it is the disease, if I follow doctrine, if they follow all, even religious doctrine, that we're treating the disease and this person's being punished for being ill more so than because if he wasn't ill, then they wouldn't be getting the medication. They wouldn't be getting this type of medication. Any of it. I mean, if he didn't have diabetes, he wouldn't have insulin. If he didn't have some sort of pain, he wouldn't be taking this type of medication. And they're going to charge him with drug trafficking. It raises some very serious concerns as to appears this is practicing medicine or exaggerating medicine without having a degree. There's nobody who had the credentials to examine this patient to even make that determination. There's just a presumption here that the person was trafficking. There's no evidence that he stopped and by the street corner and dropped something off to this person or that person. None of that.
Well, the complicating factor, Norm, is that
Yes, sir.
he's been coming to Montana every 2 weeks, and so it's been
Uh-huh.
2 weeks, and so he still hasn't gotten his other medicine back that they confiscated, and he's been unable to get his prescription filled for his next 2-week medication. So he's completely cut off. And his pharmacist is scared. And he's scared. He's just terrified. He's like a deer in the headlights. He doesn't
But
know
he
what to
still
do.
has a disease
He
presence and
does.
he needs this medication.
He does
And it's
indeed.
being withheld. And in other words, you can say that the law enforcement is withholding his treatment based on an erroneous assumption that, or our manufacturer assumption that he is somehow distributing his medicine
He's
freely
lost
and willing.
he's lost 15 pounds in 15 days. His fourth vital sign is out of control with his blood pressure. He's had to increase his blood pressure medications. And his fifth vital sign is out of control, and that his pain is uncontrolled, and he's 10 out of 10 pain. And so all three of these key vital signs are showing that he's in a lot of distress.
So let me ask you another question, because I was trying to stop asking questions, but has anybody come to you and said, Dr. Ibsen, this person had a prescription and it says that you wrote the prescription. Did anybody ask you or any authority ask you what was why was this medication being prescribed? Ask you for any radiographs, ask you any blood work? I mean, it seems as simple as saying, yes, this is my patient. This is what we and this is what I'm treating him for. And
that information is in the records that they subpoenaed me for. So if they were interested or curious or trained,
they haven't come to you yet.
Other than the subpoena, no.
It sounds like it just sounds like that they're after what we call a bigger fish. And but you are, well, I mean, but they forgot that when you're not just an average fish, you are a shark, a killer whale.
Yeah, well, yeah, I definitely, I'm laughing out of my own anxiety, but this does make me anxious, and yet there's been no contact regarding me. I should say that the DEA agents two DEA agents did visit the pharmacist several months ago, scared the pharmacist, scared the patient. Pharmacist held off on filling the prescription for a few days, and then he grew a pair.
Did they have a warrant?
I don't know.
Let me ask you, did they have a judicial warrant? I'm not talking about an administrative or inspection warrant. Did they have a warrant?
I don't know. I didn't push the pharmacist that hard, thinking that talking about warrants might make him even more anxious, and he agreed to fill the prescriptions after a few days of reflection about it. So I was just ready to be silent and not rock that boat until now.
All right.
Scott.
Okay, yeah, typing away furiously here. I was going to mention that the DEA does not require a warrant or need a warrant to perform an inspection at a registrant's site during business hours.
Thank you.
And that's national. That's not just state.
Yeah. Okay.
Scott, the issue there is they may not have that, but that doesn't stop you from exercising your constitutional right, saying that I will not talk to you because this information can be used in a criminal investigation. That still doesn't stop. That still doesn't, let's say, void your right. And that's all I have to say.
Yeah.
And is that, by the way, and is that a statute, Scott?
It's in the Controlled Substance Act, yes. It's part of the what do they call that? Administrative law. Because you are licensed by or registered with the DEA to dispense a controlled substance, they are allowed to perform an inspection anytime they choose during normal business hours.
Got it.
Yeah. If an inspection is different from an investigation, technically they would need a warrant to look at your records. But of course, they have federal judges on call, and they can have one in 20 minutes. So at least that's what I was told the last time I had a DEA investigator in my pharmacy.
It's not true.
I'd like to. May
Okay,
I step
I'll
in
just
here
leave it.
for a little bit? Uh,
Yes, sir.
Two things strike me here. That one is it sounds to me like we've got some law enforcement people who don't care and who really want to see people suffer. And I hate to say that this happens, but it sure sounds like that to me. Secondly, I noticed a couple of people here threw a note up on the screen. Should all pain patients be carrying some kind of identification or medical record or something with them when they go out in public?
One of my great mentors once taught me that yes, all patients should have quick access to medical records or some kind of identifying records that show them as a pain patient what their medications are. And with cell phones so easily these days, I don't know how others do it, but I have an iPhone and I can scan documents into my files that are resident on the phone itself, and I can scan in an entire medical record. I can scan in copies of PDMP reports, and they will lay in residence in my phone. They're not even in the cloud. So it may take some time to get it all in there. You could even do it on another computer with a high speed scanner, and then drop that folder onto your phone. So there's really no reason not to have that data with you. It's easy to get there now.
Scott, this isn't, well, here's what doesn't make any sense. What I'm disturbing, not doesn't make any, but disturbing, is that if Mr. Finn had access to his records and they were on his phone, or he had a medical verifying that he was indeed a patient of Mark Ibsen, and these were his medical records, then how was the determination that he was drug trafficking when in fact it is well understood that he needed this medication and that he had a disease, including diabetes, and yet that it seems to me the records don't matter here. This case would be dismissed, should be dismissed. How can you then take this to a grand jury and say that he was trafficking? That doesn't
It,
make any sense. And you're doing, remember, your reason you put this on your phone is so that these things won't happen, but it happened. Scott.
But
but the burden of proof is now on the state. They have to prove and show there's been some kind of diversion. And either they got to find a buyer, they got to have it on videotape, they got to find him giving his medication to somebody else. Because other than that, he's got documentation that he is, and I hate this phrase, a legitimate pain patient.
Right.
And he has records to back that up. That means they got to prove that he's not.
And the
all right,
real,
I'm going to bring all this discussion of this case to a close because we're running out of time and we've got some other issues I'd like to bring up. But give us a report next week, Mark.
I will. I promise. Yeah.
This is a tragic situation.
We need
Scott,
prayers and cash.
you bet. Scott, while I have you up here, uh, Scott, are you listening?
I'm here.
Okay, there. Uh, I had one question I wanted you to address here tonight since you're sort of involved with the medical board issue. It seems to me that the doctors of America have been scared to death to prescribe opioids ever since the CD report, which is now, about 6 or 8 years. And we've had this whole issue of doctors hardly don't even want to prescribe a codeine or an Ultram. But I think a lot of that has changed to where medical boards don't seem to have a problem with the low potency opioids. Where do we stand on getting America's doctors back to using the low dose, the low potency opioids? And where are the medical boards in all this now?
To be honest with you, I don't know where they are on that. We have our our guidelines that are out there. Unfortunately, we have board actions that don't necessarily align with their printed word, and that's what scares doctors most of the time. But from the use of low dose opioids, of I'm actively working. Well, I'm retired now, but I've been actively working in the pharmacy for the last 20 or 40 years. But over the last 3 or 4 years, probably since hydrocodone acetaminophen combination came out, your weaker opioids like tramadol, like Tylenol with codeine, are just not being used anymore. Docs go straight to the Schedule II hydrocodone products, and often they go straight to the 10-325. They're not starting off with a 5 milligram or even a 7.5. They go straight to the top dog. And we need to get back into the understanding of the lowest effective dose. Give somebody a 5. Allow them to take 1 or 2. They don't have to take a 10 milligram right off the bat. And I don't know how to get that message out. Is that a failure
Scott,
of medical schools, residencies? What?
right. Scott, you raised one disturbing question that we said before. It seems that these guys are cookbooking. In other words, they're making up the law as it goes, moving the goalposts backwards and forwards. And again, when you talk about training now in terms of medical schools, I mean, I've even heard, and someone talked about this earlier, that the in terms of the amount of pharmacology one gets is now 6 weeks. Sometimes rather than we used to get a whole year of it in terms of the medical doctors. Now they get just a flimsy course, and the rest is whatever they do in their training and stuff. So that's rather disturbing.
Well, that can kind of go back to what I heard when I was in pharmacy school in the early 1980s, where we were told at some point the doctors are trained in diagnostics. And you're right, they get very little in medications. And when I was going through pharmacy school in the 80s, we were always told that we would not get a prescription for a drug. We would get a prescription for a diagnosis and let the pharmacist choose the medication. But 47 years later or 45 years later, it hasn't happened yet. Our expertise in pharmaceuticals has been completely ignored.
Well, and that's okay. I got some issues with that one. Where pharmacists make the decision as to what drug selection that they want. I always bring the issue up. When in terms of a pharmacist, I call them PharmDs, physician wannabes, because they don't want to be a dentist. I mean, so what happens if I have a person who has a first molar where they have an accessory canal in the mesial canal, and we have to go back and go in and go back and retitrate that canal and stuff. Do you want to see those radiographs? I mean, do you know how to read those radiographs and what sort of medication that we need to treat them under? I mean, when is a pharmacist without having the proper radiograph, without having the proper blood work, without doing a physical examination on the patient? When did that was a wish dream? I mean, I heard the same stuff too, but it's that decision-making process of making the diagnosis and it's always well, as far as I'm concerned, is sacred. People want to say the physician, but also the dentist. And having being a dentist, you know, uh, I don't think very few pharmacists understand that. And I'm a pharmacist too. Understand the complexities of uh, oral health or dental It's not as simple as we may think, because in that oral cavity we have presented periodontal cancers that are unique to the oral cavity, and that's all my preaching for today.
Okay.
But go ahead, Dr. T.
In other words, right now we really don't know where all this is going, but one of the things that strikes me, we're being told that the incidence of chronic pain is going up in the country. I've heard figures like 24 million people or so. Now, what's the cause of that? What are the conditions causing us to have a higher number of chronic pain patients? What's the disease that's underlying this?
I'll take a shot at that. They often use the claim that we use more opiates than any place else in the world, and that's only true about hydrocodone because that's manufactured here, and the rest of the world uses different forms of opiates. But you could make the point, and I don't have this data, that we do more surgery than anyone else in the world, and that surgical complications are fixed. They're not zero. They're never zero. and that you slide through your total knee replacement, it's a good thing. But if it gets screwed up or infected, or the angle's wrong, or you have pain, you are SOL. And I think that the amount of surgery we do, at some point, there needs to be kind of a no fault situation, just like the car insurance industry, that if you get your fender bender, you'll find out who's at fault. But it's also, if there's no one at fault, you still get it fixed. And at this point, it's my thing is, it's ka-ching, 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 and then kick to the curb. We do, and we can do as much surgery as we want, and we do great work with surgery. I've had my share of surgery, and I'm satisfied with the results. But I think we have to admit that there's a finite number of people who are going to have complications, and we should treat them.
Now, I guess let me go back and put this another way to close out here today. We're being told that the incidence of chronic pain is going up in the country. Now, we have a show here on chronic pain. I think the first thing we need to do, then, what's the causes of this? I mean, is this all these new chronic pain patients, or all these due to arthritis due to aging? Is this all diabetic neuropathy due to diabetes and poor diets and sedentary lifestyle? I mean, is this due to headaches due to all the stresses out there? In other words, nobody has come to me or to this program and given me a satisfactory answer. Why do we have more chronic pain patients? And if so, what is the diagnosis that's causing this to go up? Because how are we going to come up with any kind of education if we first don't know what's causing this? So I'd ask all of you here, they keep talking about these increased numbers. Well, are all those poo-boos who are telling you this? I want to know what increased. Was it arthritis? Was it migraines? Was it neuropathies? Was it irritable bowel? What is it that's causing this to go up? We're having so much being told that we have a crisis on our hand and chronic pain's going up. Well, tell me why. What is it? So may I suggest that we all think about that over the week, and I'll bring it back up next week. This has been a great conversation. I wish the poor fellow in prison or jail gets out and what have you. Anyway, thanks everybody for being here.
Doctor.
Great show. We'll carry on next week. Good night.
Thank you.
Thank you.
Thank you all. And thank you, Dr. Tennant. And thank you, Dr. Ibsen and Dr. Guest. Thank you, everyone. I do want to add something that I found that was a bit important, and we'll probably go over this a little more next week, is that for those people that may be ultra rapid metabolizers, that there was a coverage that has started. It's a policy in Medicare. It became effective for many regions on July 13th of last year in 2025. And so it's usually a one and done test because your genetics don't change for your genes that they test. It includes at least 6. It is the CPT code 81418, and it's the big 3 genes and the panel rule. And it focuses heavily on how your body processes medication through the liver. And so when you get that test and you have that, then Medicare won't pay for curiosity testing, but they will pay for this. And basically what this shows is that this is one of your most powerful allies in advocating for yourself, because it legitimizes non-standard dosing. It doesn't just say, oh, the patient needs more. It literally shows the genetic reason for that. And so that should also go with that 1-page laminated paper that we've talked about before, that I think that we should remind everyone about again, is along with the 3-ring binder. I think that we should also have a laminated paper. If you can't laminate it, it can just be a 1-page paper that is in an envelope on your person at all times. And like one of our Doc Talks family members said, she keeps a paper like this on her at all times with one of the bulletins to help explain why she has these medicines and why she takes the amounts that she takes. And so on that sheet, you would just want to have the following. It would just be your name and, of course, your medicines, your medical history, And you would just want to have your main things, the main most important things of that. What would you want someone to know if you are unresponsive? And when a person is unresponsive, you don't want to make the ER guess. And so you want to have all those boxes checked, let them know exactly what's happening. And that should help. I hope it helps some people. It doesn't have to be laminated like we said, but if you just have the main points, also your allergies, you want to use your allergy list, anything that's important that you would want to tell them that you would not be able to tell them in the event, then you want to put that on that one pager. It's okay if it's front and back, but just please do that. And I hope you all are with us again next week. We will see you then. And everyone, please stay alive. Please pray for each other. Please know that you're not alone. God bless us, everyone. Thank you all, and good night.
Thank you.
Yes.
you.
Amen. Love y'all.
Love you.
Happy
Jamie, I
Valentine's
also
Day.
keep in my paper
Bye-bye.
with my craniocervical instability, because just getting intubated in an emergency, if I'm unresponsive, I'm liable to get intracranial pressure so high that I would have a stroke just from them bending my neck back to put a tube in.
It's true.
Oh, my goodness.
Yes. And a lot of people with EDS, that's a huge risk
Yes.
of having your head tilted back too far for intubation, can really be catastrophic.
Yes.
So thank you for adding that. I appreciate that. It's so important for us to fight for each other and to fight for ourselves.
Yep.
Right.
Love
Happy
y'all.
Valentine's, everyone.
Yes.
Yes.
Happy Valentine's
Yes.
Day.
Happy
not alone.
Valentine's.
Roses,
everyone.
hugs, and kisses to everybody.